G'day team, and welcome back to Overheard in the Emergency Room, the show where we unpack the two-tier blueprint for health and longevity, grounded in evidence, not hype. Today, we are going to talk about one of the most maligned topics on the internet, cholesterol. Specifically, we're going to talk about the role of cholesterol in the development of atherosclerosis and the subsequent risk of cardiovascular disease. That's heart attacks and stroke. But before we do me a favor and like, subscribe, and hit that notification bell so you never miss any of our content. Also, check out my website, drcois.com, to get free access to multiple resources. Let's get started with a case from the emergency room. Our patient today is a 63-year-old woman. She has no significant medical history and doesn't take any medications. She eats a pretty normal omnivorous diet that she prepares at home most of the time. She has a little puppy dog that she walks for an hour on most days of the week. She had a recent lipid panel which showed her LDL cholesterol was 142, so slightly elevated. She walked into the emergency room clutching her chest. She was pale, diaphoretic, short of breath, the kind of look that instantly changes the department's tempo. If you were to look up the textbook of someone who was having a heart attack, or more accurately, myocardial infarction, this would be the patient. Her ECG showed ST elevation in leads 2, 3, and AVF, with reciprocal depression in leads 1 and AVL, an inferior STEMI. For those of you who don't speak fluent ECG, that is a specific pattern which is most often consistent with an inferior occlusion. We worked diligently. We got lines, we gave pain medicines, including aspirin, and activated a STEMI alert to get the cardiologist on the phone and to get the cath lab activated. The patient had an emergent angiogram, which you can see here. That is a 100% occlusion of the right coronary artery. A stent was placed, which restored blood flow, and she survived. Here's the thing, the plaque that caused the blockage didn't form overnight. It started decades ago, and that's as good a place as any to start. Let's get into it. So, does LDL cause atherosclerosis? Not correlated with it, but actually the cause of it. If LDL is causal, lowering it matters profoundly. If it is not, then decades of cardiovascular prevention advice recommending that we get it under control may have been misguided. If you've spent any time on the internet, you will hear so many sides to this topic. Some will say that atherosclerosis is the fire and LDL cholesterol is the fireman who shows up to put it out.
So just because cholesterol is at the scene of the crime doesn't mean it's a perpetrator. What?
You will see headlines about a study saying that patients with the highest LDL levels lived the longest.
Actually, there is a correlation between LDL cholesterol and longevity. So the higher LDL, the longer you're going to live, because it has a vital role in the immune system.
And every other year, there's an article with some flashy headline saying butter is back. These all resonate with people because they are permission giving. It says to people it's okay to continue the habit of gorging on tasty foods like bacon, eggs, and cheese. All the while, the experts are encouraging diets low in saturated fat and favoring plant-based foods for protein and to increase fiber intake. The problem with this back and forth is that patients are caught in the middle, and they end up throwing in their hat saying, "Come and get me when you figured it out. I'll be at the drive-thru." Before we dive into mechanisms, let's zoom out. Cardiovascular disease remains the #1 cause of death globally. Heart attacks, strokes, peripheral vascular disease, heart failure, the whole downstream mess. It is also true that death rates have fallen dramatically over the last several decades, and there's several reasons for this. Our stenting and revascularization systems have gotten significantly better. Door to balloon times have gone down. We have stroke systems in place to make sure that patients with possible strokes are identified in the field. EMS folks will call ahead and activate the hospital that a possible stroke is on the way. We in the emergency room will clear the CT scanner and meet them at the door so we can identify and treat the problem as soon as possible. This is also due to the incredible medications that we have for treating blood pressure, lipids, and other cardiovascular risk factors. This is the work of public health campaigns that have encouraged people not to smoke and of epidemiological and experimental research on the effects of different types of fat, such as trans, saturated, and unsaturated fats. But here's what people miss. The total number of events is still enormous, and in many places it's rising again because populations are aging and metabolic disease is rising. So if we want more good decades and fewer bad days, we have to get serious about prevention. And prevention starts by understanding what causes plaque in the first place. Before we go inside the artery wall, we need to define a few lab tests and terms that you will find on a lipid panel. When you get a standard lipid panel, you usually see LDL-C or LDL cholesterol. That number tells you how much cholesterol mass is contained inside LDL particles. Each LDL particle carries one ApoB molecule. So if you're getting an ApoB on a lab test, you're actually counting the number of atherogenic particles, not just how much cholesterol they're carrying. It's important to understand that LDL-C, or the amount of cholesterol contained within LDL particles, is a reasonable surrogate for ApoB, which is a count of the LDL particles. It's the number of particles of ApoB that interact with the proteoglycans inside the arterial wall and trap cholesterol within the artery. Let's create an analogy to better understand this. Most of you have used a rideshare app. When you open the app, you see all the cars that are available on the road. Think of those cars as ApoB containing particles, LDL particles, VLDL, remnants, and Lp(a). Each car is a particle capable of colliding with and entering the arterial wall. Now think of LDL cholesterol, the LDL-C you see on your lab test, as how much cargo is in each of the cars. Some of the cars are big SUVs that seat many passengers. Some are smaller sedans carrying fewer people. LDL-C tells you how many total passengers are being carried across all the cars. This amount is calculated using the Friedewald equation, which is great if LDL-C isn't already very, very low or if the triglycerides aren't over 200. So just fine for most people in the population. But in a world where people want to be better informed prior to making decisions about their health and potentially starting medications, it would be nice if we could directly measure how many cars are on the road. Enter ApoB. ApoB tells you how many cars are on the road, and here's why that matters. Plaque formation begins when particles, the cars, leave the highway and get stuck in the arterial wall. It's not the number of passengers per car that determines how many vehicles can crash into the wall. It's the number of cars driving around. In most people, the number of passengers per car is fairly predictable, so LDL-C and ApoB tend to move together. More cholesterol cargo usually means more cars. LDL-C and ApoB are often aligned. They tend to rise and fall in many people together. But in certain metabolic states, they can come apart. The most common scenario is insulin resistance. In insulin resistance, the metabolic syndrome, LDL particles tend to be smaller and carry less cholesterol per particle. So LDL-C may not look that bad, but ApoB, the particle count, may be elevated. That means the atherogenic burden may be higher than the LDL-C alone suggests. And this is why some guidelines are increasingly recommending ApoB measurement in people who have increased risk, particularly those with metabolic syndrome, diabetes, high triglycerides, or borderline LDL-C levels, because ApoB gives you a more direct estimate of atherogenic particle number. Now, let me be very clear. LDL-C is still a strong predictor of risk. It's still very useful. It's still the basis of most clinical trials. But ApoB aligns more directly with the biological mechanism of particle retention. If plaque starts when ApoB particles are retained in the arterial wall, then counting ApoB is conceptually elegant. LDL-C measures cargo. ApoB counts vehicles. And when we're thinking about long-term arterial consequences, vehicle count tells us more about risk than cargo volume alone. Now, here's the important part for listeners. This doesn't mean you need to obsess over exotic testing. For most people, LDL-C is a reasonable proxy. But if you're in a gray zone, family history, borderline numbers, insulin resistance, ApoB can add clarity and is the test you want to get done. Many physicians are moving towards getting ApoB as a standard. Most evidence suggests that risk tracks more closely with ApoB because it tracks with particle number. And particle number drives exposure, and exposure drives plaque. LDL particles circulate in the bloodstream. Each LDL particle carries one ApoB protein. ApoB is basically the ID badge of atherogenic particles. It's what lets them interact with the arterial wall. Your arteries are lined by endothelium, a thin, living surface that is supposed to be smooth and protective. But under stress, high blood pressure, smoking, insulin resistance, diabetes, the endothelium can become dysfunctional. It becomes more permeable and inflammatory. LDL particles slip beneath that layer into the intima. Now that makes a lot of intuitive sense to people. These gaps are getting larger, allowing particles to pass through the endothelium. The reality is that atherogenic particles are small enough and can get through without damage to the endothelium. They are also transcytosed into the intima, a fancy process where they are packaged into a luggage-like structure and moved across. These particles do this all the time, moving in and out. The higher the number of vehicles or particles on the road, the greater the chance they will collide with the wall and move on into it. But once they're in the arterial wall, trouble begins. And here's the key step people skip. They get retained. Particles bind to proteoglycans in the arterial wall, becoming trapped. They're no longer just passing through. They're now sitting in a place they don't belong. Once retained, LDL becomes modified. It gets oxidized, aggregated, and your immune system treats it like a threat. Monocytes move in, become macrophages, engulf LDL, and turn into foam cells. That's the beginning of a fatty streak. The immune reaction continues as the body tries to fight off the invader. Smooth muscle cells migrate and proliferate, and a fibrous cap forms. A lipid-rich necrotic core develops, and now you have atherogenic plaque. And eventually, maybe decades later, that fibrous cap ruptures. Platelets form a clot, the artery closes. That's what happened to our patient when we started this episode. Smoking, diabetes, and hypertension, they absolutely matter. They are major accelerators, but without ApoB-containing particles being retained in the arterial wall, plaque does not begin. So mechanistically, it makes sense. Now we need to ask the next question. Does the human evidence match with the mechanism? This is where the Ference consensus statement is useful. It essentially says if LDL cholesterol causes atherosclerosis, we should see that across multiple independent types of evidence, not just one. Whoa, hold up, Dr. Cois. The Ference consensus statement? What on earth is that? Great question. This is a consensus statement that was published in the European Heart Journal in 2017 and written by over 20 research scientists, including physicians. The title of the paper is Low-Density Lipoproteins Cause Atherosclerotic Cardiovascular Disease. Evidence from Genetic, Epidemiologic, and Clinical Studies. The aim of this paper was to appraise the evidence for the role of low-density lipoproteins in atherosclerotic cardiovascular disease, or ASCVD. They set criteria for causality, which included 8 categories, and the evidence had to be grade 1. That is, conclusive evidence from 2 RCTs with no major bias. The 8 categories were as follows. Number 1, plausibility. LDL and other ApoB-containing lipoproteins are directly implicated in the initiation and progression of atherosclerotic cardiovascular disease. Number 2, strength of association. Lifelong elevations in LDL lead to markedly higher lifetime risk. Number 3, biological gradient. There is a dose-dependent association to increase risk. The higher the exposure, the greater the risk. Number 4, temporal sequence. Exposure to LDL happens prior to the onset of ASCVD. Number 5, specificity. There is unconfounded evidence from Mendelian studies and interventional trials that LDL is associated with ASCVD independent of other risk factors. Number 6, consistency. Over 200 studies involving more than 2 million participants with over 20 million person-years of follow-up and more than 150,000 cardiovascular events consistently demonstrate a dose-dependent association between the magnitude of exposure to LDL and the risk of ASCVD. Number 7, coherence. Different types of studies all agree with each other. Number 8, reduction in risk with intervention. More than 30 RCTs involving over 200,000 participants and 30,000 ASCVD events evaluating therapies to lower LDL consistently demonstrate that reducing LDL-C reduces the risk of ASCVD events, with the reduction in risk proportional to the absolute reduction in LDL-C. There are basically 4 pillars of evidence that the group in this paper analysed to make the determination that LDL is causal of ASCVD. They are: number 1, inherited disorders. Nature turns up the dial. Number 2, prospective epidemiology. Let's watch what happens over time. Number 3, Mendelian randomization. Nature runs the ultimate randomized trial. And number 4, randomized controlled trials. We intervene with some medications and we measure the outcomes. If all 4 pillars point the same way, causality becomes hard to deny. This is why I get so upset sometimes with people online suggesting that LDL is not harmful. In fact, they will often argue that higher cholesterol implies protection, or simply hand wave away the data that we're about to go through. The challenge for those online commentators is to go through this study and the data it contains and disprove it. I've never seen it done, and we will likely never see it done, because the evidence we will talk about is so strong and consistent. Let's go through each of the evidence pillars one by one. Familial hypercholesterolemia, or FH, is one of the cleanest experiments nature ever gave us. These are patients that are born with mutations that reduce clearance of LDL particles. It usually involves LDL receptor pathways, so their LDL is high from birth. These folks have genetic abnormalities that prevent their liver putting LDL receptors out on the surface of hepatocytes, so the liver can't take LDL cholesterol into the cells. So patients end up with crazy LDL-C numbers early in life. They don't need decades of poor choices, they don't need obesity, they can be lean, active, doing all the right things and still have sky-high LDL levels, enough to drive plaque formation early. And what do we see? We see premature coronary artery disease, often decades earlier than the general population. These folks will have cardiovascular events, that's heart attacks and strokes, in their 30s. If LDL were not causal, FH would not produce early heart attacks and strokes at the rate it does. But it does. So let's take a look at a study that represents this kind of research. This paper from Nordesgaard and colleagues showed that patients with heterozygous familial hypercholesterolemia typically have LDL levels greater than 310 in adults and 230 in children. If untreated, they had 13-fold increased risk of ASCVD. They also found that in a cohort of FH patients who were treated, they still had a 10-fold increased risk owing to inadequate lowering of their LDL. Again, this highlights the importance of driving LDL down in these patients. This teaches us a deeper lesson. It's not only how high LDL is, it's how long you're exposed. Your arteries remember that exposure. That area under the curve idea, as in how high for how long, is critical. It's why a mildly elevated LDL for 40 years may be more dangerous than a very high LDL for 5 years. Duration matters. So that's pillar 1. Now, pillar 2. Prospective epidemiology means measuring people's cholesterol and following them over the years to see who dies, who has heart attacks, and who has strokes. A major meta-analysis published in The Lancet in 2007 pooled data from 61 prospective studies with 12 million person years at risk between the age of 40 to 89 and 55,000 vascular events. This paper included 900,000 adults with previous disease and baseline measurements of total cholesterol and blood pressure. They found the relationship between cholesterol and vascular mortality to be log linear, meaning as cholesterol rises, risk is in fairly consistent gradient across age groups, across sexes, across blood pressure categories. Now, one issue with epidemiology is confounding. People with different cholesterol levels differ in other ways: diet, smoking, socioeconomic status, access to care. So epidemiology alone cannot prove causation, but what it does show is consistency, strength, and dose response. And dose response is important. It's not high cholesterol equals bad, low equals good. It's a gradient. And epidemiology, like the other pillars, agree with one another. So that's pillar 2. Now pillar 3 is where it gets really interesting. Mendelian randomization is the closest thing we have to a randomized trial without actually doing a trial. Here's the idea. At conception, you inherit genetic variants at random. Some variants slightly raise LDL, some slightly lower it. These differences are small, but they persist for life. So if you follow people with genetically lower LDL across decades, you can see the effect of lifelong LDL exposure on cardiovascular outcomes. Genome-wide studies identify many loci that influence lipid levels. The authors of one such study, published in Nature in 2010, screened the genome for common variants associated with plasma lipids in over 100,000 individuals of European ancestry. They identified 95 loci that encode lipid parameters in these individuals. And when they looked at those folks with genetic variants that code for higher LDL levels, they found a greater risk of atherosclerotic cardiovascular disease. This is in concordance with the other pillars of evidence we've already talked about. In addition, those with higher cholesterol levels were conferred a greater risk. Ferrin's synthesis points out that genetically lower LDL is associated with substantially lower lifetime risk of coronary artery disease, and genetically higher LDL is associated with higher risk. What makes this powerful is that these people didn't choose their LDL. It wasn't diet or exercise, it was the genetic lottery. So when we see lifelong differences in LDL producing lifelong differences in cardiovascular disease risk, that's a strong causal signal. Lower for longer wins. Not lower for 2 months, not lower after your first heart attack, lower for decades. That's pillar 3. Pillar 4 is where we talk about the gold standard. In this pillar, we'll discuss the experiment, a randomized control trial. Here we randomize people to therapies that lower LDL and see whether events drop. The Cholesterol Treatment Trialist Collaboration pooled data from 170,000 participants across 26 randomized trials and conducted a meta-analysis. To be included in this meta-analysis, the trials needed to have over 1,000 participants and a duration of at least 2 years for more versus less intensive statin regimens or for statins versus control. In the first category, there were 5 trials with over 39,000 participants and a median follow-up of 5.1 years. In the second category, there were 21 trials with over 129,000 participants and a median follow-up of 4.8 years. The long and short of this is that is a ton of people and a ton of data. The results of this meta-analysis shows one of the most reproducible relationships in modern medicine. For each 1 millimole per litre, UK and Aussie values, or 38 milligrams per deciliter, reduction in LDL-C cholesterol, major cardiovascular events drop by about 20 to 25%. That is not subtle. That is not a one-off. It's consistent across trials, population, and baseline risk levels. And when LDL lowering is more intensive, outcomes improve further. And that's why intensive versus moderate statin therapy studies show additional benefit. And here's the logic that's hard to escape. If LDL were not causal, lowering it would not reliably reduce events, but it does. So when you put it all together, inherited disorders show lifelong high LDL leads to early disease. Epidemiology, where we follow patients for decades, show that higher LDL results in higher risk of cardiovascular disease. Genetics shows that lifelong lower LDL leads to lower risk. And the trials where we lower people's LDL intentionally result in fewer events. Mechanisms colliding with genetics at the scale of epidemiology and confirmed with randomized control trials. This ticks the convergence box, which gives us the confidence to say that LDL cholesterol is causal of atherosclerosis. So hopefully now you have a good foundation as to why we can safely say that LDL cholesterol causes atherosclerosis, and are rightly asking, what can we do about it? So let's bring it back to our 2-tier blueprint. Tier 1 is lifestyle, the foundation, and this is not a wellness influencer opinion. It is embedded in the guidelines. The 2019 ACC/AHA Primary Prevention Guidelines places lifestyle interventions as the base layer. Diet quality, physical activity, weight management, blood pressure control, smoking cessation. Tier 1 is where you equip yourself with habits that reduce the likelihood of ever developing cardiovascular disease. We have already talked about these in previous episodes, and I would encourage you to go back and revisit those. The broad strokes are this. 1. Eat a plant-rich diet, one that favors foods that are rich in fiber, low in saturated fat, and choose plant sources of protein over animal sources most of the time. There are many different ways to achieve this if you like a diet label. Mediterranean, DASH, vegetarian, vegan, or look at many of the dietary guidelines around the world. Number 2, exercise for 30 to 60 minutes on most, if not all days of the week. This can be slow, continuous exercise, intervals to improve your VO2 max, and try to lift weights at least once per week. Number 3, minimize your salt intake to less than 2 grams per day. Minimize or stop alcohol consumption. Number 4, never ever smoke cigarettes. And if you do, work with your provider to stop. It's truly the most powerful thing you can do for your health. Number 5, practice stress reduction techniques. You can click on the link on the screen here and check out my channel for simple 60-second nervous system downshifts to help get you started. Tier 2 is escalation, medications and procedures, statins, PCSK9 inhibitors, angiograms, stents, bypass surgery. Tier 2 certainly shouldn't replace Tier 1. It sits on top of it. I've seen so many patients in my clinical practice who have an event, receive an intervention, and then do nothing to change their lifestyle. We are a victim of our own success in medicine in a lot of ways. Because our medical management has gotten so good and so safe that people can have a meaningful life even after experiencing a serious event. Just imagine how much better their lives would be if they prevented themselves from ever having an event altogether, or improved their physical capacity after having had an event. One of the reasons this cholesterol debate matters is because misinformation tends to push people away from both. It undermines lifestyle because commentators make it seem like lifestyle is all you need, which isn't true in many cases. And it undermines meds and other interventions by suggesting that they have significant side effects or are simply not as effective as the overwhelming evidence suggests. All right, let's talk about statins. Statins are among the most studied medications in the history of medicine, not just in cardiology, not in prevention, but in medicine. Mechanistically, they inhibit an enzyme in the liver called HMG-CoA reductase. That enzyme sits upstream in the cholesterol synthesis pathway. When you inhibit it, the liver senses that intracellular cholesterol levels are falling. And what does the liver do? It upregulates LDL receptors. More LDL receptors on hepatocytes means more ApoB containing particles, LDL, VLDL remnants, IDL, get pulled out of circulation. That lowers circulating LDL-C. More importantly, it lowers ApoB particle number. So statins don't wash cholesterol out of plaques. They reduce the number of atherogenic particles in circulation. Less particle traffic means fewer particles entering the arterial wall. Less entry means slower plaque growth. That's the core mechanism. But that's not the whole story. Statins also improve endothelial function, reduce inflammation, and stabilize plaques. In the PRINCE trial, patients achieving lower LDL levels also had reductions in CRP. This suggests that there are anti-inflammatory effects that can be layered on top of lipid lowering. Now, does this translate into a clinical benefit? Yes, repeatedly. The cholesterol treatment trialists' meta-analysis looked at over 90,000 participants in 14 randomized statin trials. For every 1 millimole per litre reduction in LDL, about 38 milligrams per deciliter, there was a roughly 22% reduction in cardiovascular events. That relationship is log linear. The lower the LDL, the lower the event rate. Then we can ask a harder question. Is more lowering better? That's where trials like TNT, IDEAL, A to Z, and Prove It come in. A pooled meta-analysis of intensive versus moderate statin therapy of over 27,000 patients showed a 16% relative reduction in coronary death or myocardial infarction with intensive therapy. Stroke was reduced by 18%. And importantly, there was no increase in non-cardiovascular mortality. So this is not just a lab number game. Now, let's talk about the side effects, because this is where the internet goes wild. Do statins cause muscle problems? Yes, some people experience myalgias. But in blinded trials, true statin-associated muscle symptoms occur in a very small minority, often less than 5%. Severe rhabdomyolysis is very rare, well under 0.1%. Do they elevate liver enzymes? Occasionally. Clinically significant liver injury is extremely uncommon. Do they increase diabetes risk? There's a small increased risk in incident diabetes, particularly in those already at risk. But the cardiovascular risk reduction substantially outweighs the signal in the appropriate patients. This is the key principle. At a population level, the benefit-risk ratio is overwhelmingly favorable in patients who meet guideline criteria. And remember something important. Most statin data are secondary prevention data. These are patients who already have established atherosclerotic cardiovascular disease. In this population, statins are foundational therapy, like aspirin, like smoking cessation. The 2018 AHA-ACC guidelines recommend high-intensity statins in patients with clinical ASCVD, targeting an LDL reduction of greater than 50%. European guidelines go even further in very high-risk patients, targeting LDL less than 55. The direction of travel is consistent across continents. Lower ApoB burden, lower LDL exposure, lower event rates, and the dose-response relationship matters. More LDL lowering generally means fewer events. That doesn't mean everyone needs maximal therapy. It means risk should match intensity. So we've had dramatic declines in cardiovascular death rates, and people sometimes use that as an argument that the old risk factors were simply wrong. But the reality is that death rates have fallen because we have aggressively attacked risk factors and improved acute care. This is where we should take a moment to discuss some of the pioneers who have helped determine what those risk factors are. First up, the Framingham Heart Study. This study is truly groundbreaking. It was funded by the US government after one of the previous presidents died from a stroke from chronically high blood pressure. They followed 3 generations of families living in Massachusetts with periodic measurements of their blood, their diets, and their genetics to better understand how these different factors contribute to cardiovascular disease risk. The work of this group and the studies published from the data they have collected have helped guide public health campaigns to lower the risk in our communities. Smoking rates have declined, blood pressure treatment has improved, and LDL lowering has become widespread. In addition, our acute STEMI and stroke systems have improved. We have strict guidelines to get patients with acute MI to the cath lab within 90 minutes. We recognize early, institute treatment, and connect patients with the intervention they need to save their lives. EMS teams can identify possible stroke as they collect patients from their homes and call ahead to emergency departments, so we can hold the CT scanner to get patients run through to institute early treatment. At the same time, incidence remains high because of aging and metabolic disease. So the correct takeaway is not cholesterol wasn't the problem. The correct takeaway is prevention and treatment worked, but we still have a lot of work to do. We just talked about how cardiovascular death rates have fallen and how LDL lowering has been central to that progress. And yet, if you scroll social media, if you listen to certain podcasts, you will hear something very different. You will hear people say cholesterol is not the problem. So let's slow this down. Let's test those ideas, not emotionally, not defensively, but systematically. Because science isn't about volume, it's about convergence. Myth number 1, cholesterol is not the problem. You may have heard someone say confidently that cholesterol is been wrongly blamed. The LDL is the bystander, that heart disease is purely about inflammation.
Big data proved otherwise, that there was no correlation between elevated LDL cholesterol and events of cardiovascular disease.
Before reacting, let's apply our framework. If LDL were not causal, then 4 things should not be true. But they are. We see premature heart disease and familial hypercholesterolemia. That's inherited disorders. We see a consistent log-linear relationship between cholesterol and vascular mortality in massive prospective databases. That's epidemiology. We see that people born with genetically lower LDL levels have dramatically lower lifetime risk. That's Mendelian randomization. And when we lower LDL in randomized controlled trials, events fall proportionally to the degree of LDL lowering achieved. That's experimental evidence. Mechanism, genetics, epidemiology, randomized controlled trials. All four converge. Inflammation absolutely plays a role. In fact, the same people who malign the role of cholesterol in ASCVD also put all of their eggs in the inflammation basket, as well as the statins don't work basket. Yet they either ignore or don't realize that statins actually reduce inflammation. But without ApoB containing particles being retained in the arterial wall, plaque does not form. So if someone claims LDL is irrelevant, their explanation must account for all four pillars of evidence. If it doesn't, it's incomplete. Let's move on to the next claim. Often when LDL causality becomes hard to dismiss, the argument shifts. It becomes about diet. Myth number 2. Saturated fat doesn't raise cholesterol. You might hear someone say that saturated fat has been unfairly demonized, that dietary fat doesn't meaningfully influence cholesterol.
Say that saturated fat is bad for you, increases your risk of cancer. This has never been conclusively shown in any randomized controlled trial. So we know that butter, probably the quintessential saturated fat, lowers CRP. It lowers inflammation. Saturated fat from dairy has consistently been associated with better health outcomes.
Let's test that. In tightly controlled metabolic ward studies where intake is measured precisely, replacing unsaturated fat with saturated fat increases LDL cholesterol in most individuals. Mechanistically, saturated fat reduces LDL receptor activity in the liver. Remember, we already talked about how folks with familial hypercholesterolemia are unable to produce LDL receptors on the surface of the liver and can't suck those LDL particles out of the blood. By intaking saturated fat, you have a similar effect and have reduced receptor activity and therefore fewer ApoB particles being cleared from circulation. That means higher LDL levels. Now, is there individual variability? Of course. Does every person respond identically? No, but directionally, the physiology is established. And again, let's run the four pillars. If saturated fat increases ApoB particle number and ApoB retention initiates plaque formation, and higher LDL levels correlate with higher event rates, and lowering LDL reduces events in trials, then this dietary effect is mechanistically relevant. Mechanism, genetics, epidemiology, randomized controlled trials. All four converge. Let's shift to the next variation of this argument. When cholesterol causality becomes difficult to deny, the explanation often pivots again. It's not cholesterol, it's inflammation. Myth number 3. It's all inflammation. Now, this one sounds sophisticated, and it's partially true. Inflammation is involved in plaque progression and rupture. But here's the question. Can inflammation alone create atherosclerotic plaque without LDL retention?
Causes this to become inflamed? How does stress directly impact that?
Chronic stress as a risk factor for heart disease, proven to be equivalent to the risk of smoking, having high blood pressure, or having type 2 diabetes.
The answer is no. Inflammation amplifies. LDL retention initiates, but you can think of inflammation as gasoline fumes. And the most disingenuous part of this argument is that they are forgetting that the majority of people who suffer from cardiovascular disease are not just suffering with inflammation. Inflammation most often travels with other comorbidities like metabolic syndrome, obesity, hypertension, and smoking. It's smoke and mirrors, and just nebulous enough that you might be convinced to buy a supplement they are selling you to fix your inflammation. Just remember, ApoB containing particles are the fuel. Remove the fuel, the fire can't ignite. Again, mechanism, genetics, epidemiology, randomized trials. The inflammation narrative does not replace LDL causality, it layers onto it. Now let's address perhaps the most consequential myth, because this one directly affects whether people accept treatment. Myth number 4. Statins don't work. This is not an abstract debate. This affects real patients. We can keep coming back to this meta-analysis of randomized controlled trials. If you can't refute this paper and the results, you have no chance of the argument that statins don't have a benefit holding up.
Statins. Most of those people taking statins are either low risk or high risk primary prevention. Over a 5-year period taking a statin, the benefit is 1 in 100.
Across more than 170,000 participants in randomized control trials, lowering LDL cholesterol reduces major vascular events by roughly 20 to 25% per 1 millimole per liter reduction, or 38 milligrams per deciliter. That effect is consistent across risk groups, across age groups, across decades. If LDL were not causal, lowering it would not reliably reduce events, but it does. Mechanism, genetics, epidemiology, randomized control trials. For the final time, all four converge. When someone says statins don't work, they are not simply challenging the medication, they are rejecting randomized evidence. Now, I want you to notice something. When experts talk about these topics, they speak with nuance and express uncertainty. Even I, as an emergency room physician who actually treats folks with acute heart attacks, rely on experts and their opinions on these matters. When lipid experts like Dr. Thomas Tayspring and Dr. Muhammad Allo discuss this topic, they don't rely on bold declarations. They talk about ApoB particle number, cumulative exposure, dose response curves, lifelong risk modification. They reference mechanism, they reference randomized trials, they reference genetic data. That is how science talks. It's layered, it's measured, it talks about the convergence. So here's a simple filter for you. When you hear a bold claim about cholesterol, just ask, does this explanation account for the mechanism? Does it explain the genetics when folks have genetically elevated cholesterol? Does it align with the epidemiology? And finally, does it survive the randomized controlled data? If it fails one pillar, be cautious. If it fails all four, it is misinformation. Don't be impressed by confidence, be persuaded by convergence of lines of evidence. This episode isn't about winning arguments on the internet. It's about preventing the next 63-year-old woman from clutching her chest in the emergency department. That could be you, your mum, your auntie, or your grandma. In order to do that, we need to translate evidence into action. So let's bring it back to our blueprint. And here's your weekly call to action. I want you to know your numbers, know your LDL, know your blood pressure, know your family history. We will talk more about lab tests in an upcoming episode. Build tier 1 like it matters, because it does. Diet quality, daily physical activity, sleep, stress regulation, and working with your doctor. And if you need tier 2, use it wisely and without shame, under the guidance of your primary physician. Don't be scared, be prepared. All right, let's land this episode by going back to the start and the case of the 63-year-old woman who did everything just about right. Didn't have any major medical history, she walked her dog, she had home-cooked meals, but her LDL was 142. She still ended up with 100% right coronary artery occlusion. That plaque didn't form overnight. It formed over decades. It did this silently, cumulatively, and in many cases, it was preventable. Your arteries remember your LDL. They remember every ApoB containing particle that crossed that endothelial barrier and stayed there. Remember, lower for longer wins. Now, how do we know that LDL causes atherosclerosis? Not correlates with it, not associates with it, but actually causes it. It's because of the 4 pillars of evidence. Pillar 1, the epidemiology. Across populations, across blood pressure strata and age groups, higher LDL tracks with higher rates of vascular death. The relationship is continuous and log linear. There's no safe upper threshold. More exposure equals more events. Pillar 2, genetics. Mendelian randomization studies show that people born with lifelong lower LDL due to genetic variants have dramatically lower cardiovascular disease risk. It's nature's randomized trial. The reverse is true of familial hypercholesterolemia. Very high lifetime LDL leads to very early disease. Pillar 3, mechanistic biology. We can see LDL particles in the plaque, we can observe oxidation, macrophage uptake, foam cell formation, and fatty streak development. It's not theoretical, it's histology. It's direct biological plausibility. And Pillar 4, the randomized control trials. Lower LDL with statin leads to lower cardiovascular disease events. The magnitude of the benefit tracks with the magnitude of LDL reduction. When all 4 of these pillars point in the same direction, we are no longer debating correlation. We are describing causation. It often has a pattern. It cherry picks one observational study in elderly patients and ignores lifetime exposure. It confuses total cholesterol with ApoB particle number. It dismisses randomized trials, but leans heavily on anecdotes. It uses emotionally charged language like cholesterol is innocent, statins are poison, cholesterol is just the fireman showing up to put out the fire. It presents a false binary. Either that LDL matters or inflammation matters, when in reality inflammation and lipoproteins interact biologically. and cause disease. If someone's telling you that LDL does not cause atherosclerosis, they must dismantle all 4 pillars, not one, all 4. That is the burden they must meet. Now, what do we do with this? This is where our 2-tiered framework comes in. Tier 1, the foundational lifestyle. Heart-healthy dietary patterns, minimize saturated fat excess, increase fiber, maintain metabolic health, exercise, sleep, avoid tobacco. These interventions reduce ApoB burden, improve insulin sensitivity, and reduce inflammation. They matter. Tier 2, the targeted medical therapy if risk warrants it. If your lifetime risk is high, if you already have ASCVD, if your LDL remains elevated despite lifestyle optimization, if you have genetic risk like familial hypercholesterolemia, then medication is not a failure. It's biology. The goal is not perfection. The goal is lower exposure over time. Lower for longer wins. So don't be scared, be prepared. Know your numbers, understand what they mean, ask about ApoB and your lifetime risk. If you found this episode helpful, it really helps us cut through the noise if you can like, subscribe, and hit the notification bell so you don't miss our content. Also, head over to drcois.com for free resources to help you build your prevention blueprint. Because heart attacks don't start in the cath lab, they start decades earlier. See you next time.